I just let the dog be kind of just relaxed in the room as much as I can, but I'm watching it. I'm already starting a bit of that gait evaluation and observation right from when they're just wandering around the room.
Hey there, VetFolio Voice listeners. Welcome back. I'm so happy you're joining me for this episode. For this episode, I was joined by Dr. Clara Go to talk about a topic that's a bit outside of my comfort zone, and that's the orthopedic exam. I mean, despite having many conversations about how to perform an orthopedic exam, I don't know that I've ever really developed a comfort level with my ability to do it effectively. And truthfully, I was even a little bit worried going into this conversation that kind of my lack of comfort in this area would come through. And maybe it did, I don't know. But listening to Dr. Go, something clicked for me. And I can promise this is something that's come up in conversation before, but something about the way she explained it gave me this light bulb moment when she noted that the purpose of the orthopedic exam isn't necessarily to get a definitive diagnosis immediately. The goal is to localize the discomfort to a specific limb and a joint or possibly two. Now, since having this conversation, I've encountered several limping dogs, and I have literally repeated that out loud to myself. Just localize the limb, get it down to a joint or two. And somehow for me, that's reduced the overwhelm and made me feel a lot more capable of doing what I'm there to do, and ultimately has made me a much more effective clinician in these cases. We also talked about a dilemma I know I've struggled with multiple times, and that's how to approach sedation and radiographs in a patient for which I suspect a cruciate injury, and I know I plan to refer to a surgeon. If the diagnosis isn't crystal clear, I find myself kind of on this fence of wanting to do a sedated orthopedic exam and take radiographs to further support my diagnosis before I recommend referral, but also not wanting to set the pet or the owner up for having to repeat diagnostics. So Dr. Go had some really helpful recommendations on how to streamline the process to get a definitive diagnosis without multiple sets of x-rays. Let me go ahead and introduce her and we'll get into it. Dr. Go earned her veterinary degree at Sydney University in Australia. She completed her postgraduate specialty training, which was a rotating internship, a surgical residency, and surgical oncology fellowship at Colorado State University, where she currently holds a faculty position in small animal orthopedic surgery. Her clinical and research interests include cruciate disease, hip dysplasia, and minimally invasive surgery or arthroscopy. Dr. Go has been an invited speaker and instructor at numerous conferences and surgical labs throughout the United States, supporting continuing education of veterinarians from around the world. She's also the current small animal surgery program chair for the North American veterinary community. She was an absolutely wonderful guest, lots of really helpful insight. Let's go ahead and get into it.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serolaner Moxidectin and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serolaner belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
Well, I'm excited to be joined by Dr. Clara Go. We're going to talk about orthopedics, which I don't think I'm alone in saying orthopedics is not my comfort zone. It's an intimidating area when we start to get into lameness and things like that. So I'm excited to dive into it more and increase that comfort level. So thank you so much for joining me.
Thank you for having me, Dr. Cassie. It is definitely a bit of a passion of mine. I do also hear a lot of people, particularly like new grads, that will come up to me and just say, I'm just not comfortable with orthopedic exam or localizing a lameness. And it is something that I've obviously devoted a lot of my life to in teaching and am still refining myself. So definitely something I'm excited to chat about.
Yes. I'm always excited to learn more. I love having these talks that are a little bit out of my comfort zone because I always take something away. I don't know that I'll ever develop the comfort level and the passion that you bring to this conversation. But, I always feel like I can tweak things a little bit and get a little bit better. And it's so rewarding when that happens. And then I am able to pick up on a different type of lameness. But before we go too far into the specifics, when you say an orthopedic exam, even just like thinking of that terminology sounds a little intimidating. Like, oh gosh, do I know how to do an orthopedic exam? What actually is that? So can we start there with talking about what does it mean when we say an orthopedic exam? What are we looking for? What does it encompass?
Yeah, absolutely. To me, it's a bit of an expansion of just your general, not just physical exam, but truly an observation, I would call it, of the patient. And to me, it kind of comes back to that whole Dr. Dolittle thing of asking the pet to tell us like where it hurts, right? That's really the bottom line. And asking an animal, which is kind of a big ask, I think, because that animal's probably in an unusual and to them likely scary environment. And then to me, that is even a bigger ask to then ask them to give us hints and clues about like what is going on, what's wrong, what is painful, so that we can localize the injury or the lameness and then come up with a bit more of a diagnostic and treatment plan. So that to me is exactly what the orthopedic exam is.
That makes a lot of sense from multiple perspectives. One, from the idea of trying to get an animal to tell us where it hurts, and that being a challenge because, of course, their instinct is to not tell us where it hurts. And it kind of, I think, speaks to why these can be challenging. And then also, I had the opportunity to talk to you a little bit before we turned the microphones on. I think we talked last week a little bit. During our conversation, you said something about, we want to know what limb it is, what joint it is, just narrow it down a little bit. And that kind of took the intimidation out a little bit to the point where this week I had 2 lameness cases back to back. And I had that intimidation that I feel like I always get when it's a lameness. Am I going to be able to figure this out? And I heard you in my head saying, just figure out what limb and see if you can narrow it down to a joint. And it made it seem like something I could accomplish a little bit more easily and not feel quite so intimidated by.
Absolutely. Having a bit more of let's take the intimidation out of it and break it down to simple things of what am I trying to look for? And then again, how do I go about physically approaching the exam so that it doesn't seem so intimidating anymore?
Getting the dogs to tell us where it hurts when evolutionarily they are not inclined to do that. The number of dogs, and I tell this to owners, I say, because their dog will come in and of course is not limping. And they were limping right up until the point they walked into the clinic. And then adrenaline is surging. And, I have a pet owner there saying, I swear he was limping at home. And I'm saying, I believe you, it's the adrenaline. And they were limping right up until they walked in the door here. So all that to say, when they don't want to tell us where it hurts, these signs of lameness can be really subtle. Can you give us some hints on how to approach those cases when we don't have, say, like a 3-legged lame dog or something, and it's a lot more subtle and harder to pinpoint what limb and especially what joint?
The first thing that I try to do is almost use a bit of a profiling approach sometimes. Part of that is, how can I tease out a little bit from the dog's signalment and what the owner's telling me from history about, and is this a hind limb? Is it a forelimb? What are going to be some commonalities, things that we can sort of clue into, the hind limb lameness that kind of is a little bit on and off and more with exercise, maybe a little bit worse when the dog first gets up after rest. I'm already starting to think, is that a cruciate? Is it hip dysplasia, in my brain? So some of those things can be teased out a little bit from what your owner gives you in the way of that history. In this day and age, another thing which we found very helpful is people almost inevitably have a video of their dog. And oftentimes, especially if this has been a lameness that has a little bit been intermittent or they only see it now and then, it's not uncommon for them to have maybe captured some of the times when their dog is more lame on video. When I do ask to see, or if they have a video, or I'm asking the owner for a video, say I see the pet, it's very subtle, it's really not showing me any lameness in the hospital, I could send send them away and say, okay, well, can you try and capture some video when your dog actually is showing this lameness, but be pretty specific about what I want from those videos. So I'm not going through, 3 hours of funniest home video of the dog doing cute things and sleeping in the bed. What I'm wanting is probably 2 to 3 short, sort of 10 to 20-second type video clips of the dog showing the lameness. So somebody else walking the dog, the person videoing is capturing the dog, not from too far away, but not from too close, seeing the dog walking away and towards the camera, seeing the dog walking across the field, from one side to the other from the side, maybe even capturing the dog sitting and standing. So doing a couple other motions as well. But that to me can be pretty useful because I feel like most people have a smartphone. And again, owners are usually pretty willing to partner with you to getting some of those short little video clips that you're after.
Sure. And with the smartphones that we have, I mean, we can even get like slow motion videos and it's amazing what we can see now that we just didn't have the opportunity to get before.
Absolutely. And then, those dogs are in their own environment. They're more comfortable. They're, probably not going to hide as much of that lameness, especially if it's subtle. I do find that particularly helpful with cats as well, because I feel like cats just, if I'm trying to do a gait evaluation on a cat in the clinic, it's almost impossible sometimes to get them to walk in a more normal fashion. But even when I'm in the clinic, some things that I find is almost that more fear-free approach of try to be that animal's friend before you're their doctor. So while I may be talking to the owner about history and gleaning things, I just let the dog be kind of just relaxed in the room as much as I can, but I'm watching it. I'm already starting a bit of that gait evaluation and observation right from when they're just wandering around the room, as much of a relaxed state as they can be.
Absolutely. I couldn't agree more. Whether it's lameness or another diagnosis, I think we get so much information just from that couple of minutes that we sit there and chat with the owner and just watch the dog and watch their behavior, what they're doing. Because I think in those moments, rather than when we're kind of hands-on with them and maybe they're a little bit more timid and not willing to show us as much, we can get a lot of information just from that initial observation. I feel like with what you were saying with getting specific videos, I appreciate those recommendations. I feel like maybe you have some personal experience with the 3-hour America's Funniest Home Videos.
Yeah, I do get a lot of video that is like the owner trying to like video the dog as they're walking the dog, and I'm seeing like maybe one leg out of focus, catching it here and there. So yeah, being pretty specific about what you're specifically looking for on the video and keeping it short. I don't need like hours and hours. I need like 1 good minute at most.
Absolutely. Yeah, you're only going to see so much.
Yeah.
You also did hit on something I wanted to dive into a little bit further, where you said, as you're kind of getting the history here, and maybe in some of these videos, you're looking at the dog sitting or going from sitting to standing, it'll start to give you some clues. How can those types of findings help us to narrow this down? We'll hear some dogs where they're stiff when they first wake up in the morning, and then as they warm up, they move more easily. And then, of course, the opposite, where they're fine until they exercise, and then they're lame after they exercise. And then, of course, sitting and standing and things like that. How can those clues help us pinpoint what we're looking at?
Yeah, absolutely. I think a lot of it comes back to what are we looking for, honestly, in our gait observation, right? And that's really the first part of my orthopedic evaluation is, what am I looking for? And I think when it comes to that observation of an animal moving, whether it's walking, whether it's getting up from sitting, whether it's going down into a sit, I think understanding a little bit of how a dog or a cat shifts its body weight or adapts to having a painful limb can be pretty powerful in then actually transitioning that to, okay, well, what am I now looking for as part of this gait exam? When I'm actually focused on the pet and I'm trying to see, what am I looking for? And somebody, explained this to me in such an eloquent way. It really stuck with me, is that if we think about a dog with that sort of sawhorse classic sort of stance, you would think, okay, well, 50-50 weight distribution, forelimbs, hind limbs. But then they do have a head, obviously, which makes them a little asymmetric. So, a healthy, happy dog is 60% weight distribution in forelimbs and about 40% in the hind limbs. So say now I take this dog and it has a hind limb lameness. What are we going to see differently in that? What we might see for a hind limb is that, especially if it is potentially a bilateral hind limb lameness, there will be a pretty significant weight shift forward, right? And how does the dog manifest that as part of its gait? It's probably going to walk with its head lower, so that lower head carriage throughout a lot of the gaiting can be a little telltale of, okay, this dog is trying to get weight off its hind limbs. Even when they stand there, you may notice, okay, that weight shift forward again, the slightly lower head carriage, the slightly more upright sort of stance in the hind limbs. And that is, again, them shifting weight away from, a painful limb. When they planting the feet, what we look for there is, okay, when the lame leg hits the ground, it's probably they're going to try and shift or propel themselves so that they don't have to bear as much weight on the painful limb. And then they'll probably land a little heavier on the side that is the sound side. And sometimes you'll see that. So you'll see either the hip hike and then the sort of drop of the hip, or I actually find it easier to look for the drop, the down on sound of the hock, because it's a heavier footfall and that hock will often drop a little bit lower. Dogs with long tails, another telltale sign is that their tail will often go towards the sound side, when they plant that sound leg. And again, that body shift, that weight shift away from the lame side, the tail actually points, if you watch pretty carefully, swings towards the sound side because they're dropping, again, that body weight a little more heavily to that side. So those are some subtleties for a hind limb lameness. Well, what same sort of goes for a forelimb lameness. So in the forelimb, if the dog has a painful limb, how can it shift its body weight so that it is not going to have to plant as much weight on that painful limb? It'll raise its head because that shifts that body weight again further back. And so that lift of the head on that painful leg, maybe the drop of the head on the sound leg, that is actually what we look for to identify those gait changes. And it sort of made so much sense to me. I've always heard watching for the head raise or the hip hike or the down on sound, but I never quite understood it. And I think once I understood why the animal was doing that, it almost made it a little easier for me to observe it.
That does make sense. Thinking about the biomechanics. And yeah, I definitely just had a light bulb moment there when you were talking about the hind limb lameness, because when we see a forelimb lameness, at least if it's pronounced enough in the clinic, certainly, down on sound. And I feel like I can observe that a little more readily. But when it's a hind limb lameness, that's always thrown me where I'm like, I just don't feel like they move their head the same way. I can't pinpoint this in the same way.
Yes.
But the way you described thinking about the biomechanics there and how they're going to move to shift the weight off of the affected leg, even so much as watching the hock and things like that, it makes so much more sense in pinpointing those hind limb lamenesses. Because, so many times, at least in larger dogs, we'll see a non-weight bearing lameness that's a little more obvious. But when it's not an obvious lameness, especially in the hind limb, I know that's an area where I've struggled a lot. So yeah, thank you. That makes a lot of sense.
The other thing with the hind limb that, is a great localizer is asking the dog to sit as well. So, when we ask a dog to sit and we try not to sort of push their sort of butt down if they're not willing. It's sort of like more of just a request with a treat, maybe to ask them to sit. When they go to sit, naturally, dogs to sit squarely have to fully flex the stifle and the tarsus in order to sit squarely. So if they have a cruciate tear, if they happen to have tarsal OCD or something like that, they are going to have an abnormal, or what I call a positive sit test, meaning that that is an abnormal way that they sit. So classic would be the cruciate dog. They will shift weight when you ask them to sit away from the lame leg. And instead of sitting nice and squarely, they'll often kick that lame leg out to the side or behind them, or sometimes they'll tuck it forward. The classic is a bilateral cruciate dog. So those bilateral lamenesses are often trickier for us to visualize than a unilateral lameness because you don't see as much asymmetry. Although in the case of a dog with bilateral cruciate disease, often they will have that massive weight shift forward. So that lower head carriage, maybe both legs look a little bit stiff or stilted. But then when you honestly ask them to sit, it becomes obvious. They will weight shift forward. They will kind of shuffle around their hind end because they really don't want to fully flex those stifles. And then they'll often kick both of the hind legs out to the side or behind them, or they'll tuck them kind of awkwardly. And that to me really does sort of make me think, okay, I know this dog has a bilateral hind limb lameness. I'm really suspicious of bilateral cruciate disease because of the way it sits. And I haven't necessarily even put my hands on the dog yet at that point in time.
So much information just from the gait evaluation. And I want to get further into evaluating the joints, but real quick, I'm thinking of a bilateral hind limb lameness. We think of bunny hopping with hips.
Yes.
Will we see that with bilateral stifle disease as well?
You oftentimes will. The bunny hopping is pretty characteristic of hip dysplasia because they're avoiding the hip extension. So as a dog goes into the end of its stance phase and into the swing phase of its gait, that's really where we see a lot of that sort of hip extension coming into play. And so it's classic for a dog that has bilateral hip dysplasia. It will not want to fully extend at the hips. And so as they want to get up to faster gaits, instead of reaching back and going into more of that extension, they'll shorten that extension phase and that'll turn into like a bunny hop because it sort of shortens the gait. A dog with hip dysplasia will walk differently to a dog with cruciate disease. And once you get used to picking out the differences, it's hard not to see it. So a classic dog gait with hip dysplasia will be more narrow based, but they'll have a prominent hip sway. It's almost like we call it a tight skirt gait, like they're wearing a pencil skirt, because what they're trying to do is they're avoiding actually moving the hips around through range of motion. Instead, they'll pick up the whole pelvis and kind of sway it side to side as they're walking.
The Dolly Parton walk, we called it in
exactly.
cows. Yeah.
So it's very characteristic because they are compensating. They will often have the lower head carriage. The fun part is when you ask a dog to sit, okay, you have two dogs. One has bilateral hip dysplasia, one has bilateral cruciate disease. The dog with the bilateral cruciate disease, its walk won't look narrow-based. It'll have a wider stance. Typically, they're stiff. They don't really want to flex at the stifle. So how do they advance the leg? They kind of have to almost circumduct it out to the side. And so they won't typically be narrow-based. They'll be often, if anything, wider-based as they walk. Both of them will have a shorter gait. Both of them may bunny hop when they go up to faster gaits because they're both trying to sort of avoid motion in the joints. But more commonly, the hip dysplasia dog probably is going to bunny hop faster, like go into a bunny hop faster than the cruciate dog will. But when you ask them to sit, the dog with the cruciate disease will almost guaranteed have a positive sit test, as in it's not going to sit squarely. The dog with the hip dysplasia will actually sit pretty squarely because when you think about a dog with hip dysplasia, they're not often as painful to hip flexion. And when they're sitting,
Right.
the hip actually doesn't have to fully flex. So they're actually probably pretty comfortable with sitting. In fact, dogs with hip dysplasia often have a history of they prefer just to be more sedentary. They're often sitting or laying down more often than they are up and on their joints, up and on their feet. So the sit will actually look pretty square in the dog with hip dysplasia. Now, you may notice a difference when that hip dysplasia dog gets up from sitting, because that does take some strength in the glutes and some hip extension in order to get up from sitting. They may teeter-totter their weight forward, lean their head nice and low so that they can almost leverage or teeter-totter their hind end up instead of using that strength and extension in the hips. But that slow to rise, to me, doesn't necessarily mean abnormal sit test like the cruciate dog. So again, some key differences that, sometimes I go to the dog park and I'm like watching dogs run around. I'm like, oh, cruciate disease, hip dysplasia, here's my business card.
Love it.
Like once you see it and you start to see these changes, it's hard not to see it.
I could see it because the few lamenesses that I do feel confident in picking out, they do become very clear when you see them, or even like the histories. The dogs that sometimes I feel like I can diagnose just based off the history, aside from I was running in the yard and now I'm three-legged lame, like the Chihuahua that just doesn't want to move, and I'm like, oh, your neck is sore before. It's almost like before they even walk in the door, and of course, it's not always the case, but once you start to get the hang of what these dogs and cats, I guess, cats I think are really difficult to diagnose, look like, I could see that it's hard to unsee it and becomes much easier to pick out. I will say, I think the last time we talked about someone being at a dog park and recognizing things, it was parasitologists going and collecting stool samples from dogs at the dog park. So I would imagine the pet owners are much more receptive to you walking up and talking about lameness as opposed to collecting poop.
I know. Well, in general, I try to avoid the whole approaching dogs owners at a park just because it gets a little difficult to get out of that situation.
Agreed. Absolutely. Okay. So, all of that just based off of gait evaluation before we've even really, put hands on this animal to assess the individual joints, already gathering so much information. So then let's move into the orthopedic exam itself. And and we've calmed these dogs down and we've got an idea of where our lameness is based on gait evaluation. What are we looking for when we're actually physically examining the different joints?
Absolutely. So with the hands-on part of the exam, I like to start off with like kind of an overall standing exam first, and then I'll go into more of a hands-on manipulative exam. With my standing exam, really what I'm doing is just looking for asymmetries. So I'll try and make sure the pet is standing relatively square, and I'll work my way kind of from proximal to distal, feeling both sides at once. And what I'm looking for is asymmetries in muscle mass, which it is important that the dog is weight bearing fairly evenly for this part, because sometimes if they're, shifting their weight off one leg, I may interpret just changes in muscle tone with true change in muscle mass itself. So sort of squaring them up show dog style, and then just, feeling my way proximal to distal, feeling for any muscle atrophy, any thickening around any particular joints. It's a great part of the exam, especially for like those cruciate dogs, to feel for quadriceps muscle atrophy when I'm feeling both quadriceps and hamstrings kind of in the hind thigh. As I get down, over the joints, really feeling, do I feel effusion? Again, great part of my exam. When I'm got them standing, I'm feeling both sides to feel for stifle effusion or medial buttress for the more chronic cruciate cases, and then kind of working my way down. So that part is almost like an initial screen. I might have been, again, suspicious from my gait, suspicious from watching him. Now I'm like, okay, well, how can I add to that, localization? Okay, I was thinking it could be a cruciate. Yes, this dog also has some quads quads atrophy, it's got some effusion, it's got a little buttress. Okay, I'm still thinking cruciate even before, again, I start to actually physically feel for the joints themselves. So once I've done that localization, then I do start to feel the joints themselves and the bones. And for this part, it can either be with the pet standing or with the pet in lateral recumbency. I go with, again, whatever I feel like this dog is going to be most comfortable with. They're painful, they're weak. It's going to be hard on them to like bear weight on the other three legs as I'm trying to do my joint manipulation. So they may be more comfortable actually being supported in lateral recumbency versus some dogs are the more, hands off. I don't really want a bunch of hands like holding me down on the floor. So they may be better off with just standing, maybe just a handler, just, keeping a hand, just patting them and keeping a hand around their collar, and me doing the manipulations with them standing. And with my manipulations, I do, again, try to be methodical. So I work my way from distal to proximal on the limb. And there, I keep an acronym in my head, CREPI. So the C is for crepitus, R is for range of motion, E is for effusion, P for pain, and I for instability. And that's really the things that I'm trying to feel for in any of the joints. So as I'm working my way again from distal to proximal, picking the sound limbs first and then going to the more painful limbs, just so that I'm getting an idea of, okay, how toe sensitive is this dog? How does it respond just to my general manipulations in general? But those crappy things are really the things that I'm trying to tease out. Can I feel effusion? Can I feel a decreased range of motion? Can I feel some pain? Am I getting a pain response? Now, the pain response thing is something obviously we try to temper, because I think especially early on, sometimes I see some students being a little bit rough, honestly, with their manipulations. And especially we have to be a little cautious with extension of joints. So, with most joints, if you think about, say, your elbow, you can flex that joint and push it into full flexion and even push a little harder. And it's probably not going to hurt you to really push pretty hard in flexion. But if you go to extension, and even if you have a completely healthy elbow, at some point, if I were to push that really hard into hyperextension, that is going to hurt. and you're probably going to try and bite me at some point in time. And so that is one thing I try to tell my students is, test first in flexion, because if a joint is showing you, or that dog's showing you a pain response in flexion, that is probably a painful joint, and you want to be a little bit more gentle and more careful. You don't need to have the dogs cry out in pain. If they are showing you, they're trying to pull away, they're looking, they're resisting, they're giving you some resistance, you can tell that is actually a painful joint, and especially if you've already paired that with, okay, well, I sort of know from my gait evaluation, this is a painful limb. I know from my localization, okay, I'm suspicious of a cruciate. It's got some quads atrophy. It has some effusion. I'm feeling a little bit of crepitus through range of motion. I don't need to make that dog cry out in pain to know that, yes, this is likely my joint of suspicion. The instability part is one that I think, again, takes a little bit of a practice to know for each specific joint, okay, where am I going to put my hands to feel for, say, cranial jaw or tibial thrust in the stifle joint? And I do try to be pretty specific. So let's pick on stifle disease and cruciate disease. I do try and make sure when I'm feeling for cranial jaw that my index finger of my distal hand's on the tibial tuberosity, that my thumb is on the lateral fibula, that my thumb of the proximal hand is on the, fibula head for my distal finger, for my thumb of my proximal hand, that's going to be on the lateral fibula, and my index finger on the patella. And so I do try and look for those landmarks and not just randomly sort of grab over the stifle in a random fashion. And I am trying to specifically stabilize the proximal side and see if I'm feeling for any instability on the distal side to that draw type of motion. Tibial thrust, sort of similar, but my proximal hand, the index finger, instead of being on patella, is going to sail down that patella tendon down onto tibial tuberosity. And my distal hand is going to grasp at the hock and sort of flex at the hock, as well as sort of almost compressing the tibia. That's why it's also called sometimes the tibial compression test. What we're trying to mimic with tibial thrust is them taking a weight-bearing step, because then that activates our gastroc mechanism, and that's what gives the force vector that actually shifts the tibia forward if they have an insufficient cranial cruciate ligament. So I think it's one of those, again, tests that if you know exactly where your fingers are meant to go, what your action is that you're trying to exact, that can help, again, to just understand, okay, what am I specifically looking for here with this specific test?
That is really helpful to kind of visualize it. Yeah, my hands, they do tend to go to the same spot every time I do those tests. And if you move them in a different way, it doesn't work. You really don't get the same results. The other thing I'm curious to know your feelings about it is, especially if I have a dog who wants to lay laterally, one thing I've found that has helped me determine if I have a positive cranial draw or tibial thrust is I'll almost like lay their back leg over my leg, so it's supported. And that seems to help them relax a little bit, where I can get a little bit more movement out of that stifle.
Absolutely. I mean, I think the more relaxed and supported that dog feels, the more likely it is going to relax more and allow you to feel for that instability. Because obviously it is a vulnerable thing, that it is their painful leg, obviously. So sometimes I find, even with some of the dogs that are a little bit more nervous or more anxious, having them standing is actually, to me, an easier position to feel. They're almost in an ideal position anyway, with being in that sort of standing weight bearing position. So you can sort of slide your hand, proximal hand down, find those landmarks, and then just sneak your other hand down and sort of gently flex at the tarsus. The tibial thrust, to me, is a harder test to learn how to do it well. But then once you learn how to do it well, it seems like the dogs tolerate that a little better than cranial draw. And so I often will test for my tibial thrust before I actually check for cranial draw, often just because if I am getting positive, tibial thrust, yes, I'm ticking off all the other boxes for the lameness, for the quads atrophy, stifle effusion. I don't always probably need to check for cranial draw as well while that dog is, unsedated and fully awake, to say, yes, I think this dog has cruciate disease.
Oh man, that is going to be my like goal, is to get so comfortable with my tibial thrust test that I don't have to do the cranial drawer. I do feel like I get decent results when I do a tibial thrust, but I not enough where I'm confident to not try to do a cranial drawer. And you segued perfectly into where my brain was going next when it comes to relaxing those muscles and sedation. That was one thing that, we were taught in school, and our surgeons were very serious about it. They said, if you can't find tibial thrust or cranial drawer, sedate the dog, because these dogs are strong. And when they tense up those muscles, you might not get a lot of movement out of that stifle. Whereas if you sedate them, all of a sudden, there it is, and it becomes very obvious. Where I struggle is one, I do feel like I can get a decent idea when I compare the two stifles. But, you mentioned bilateral cruciate disease, and then that just throws a monkey wrench into the whole thing. So where I struggle when it comes to sedation is, okay, I'm going to sedate this dog. And if I find a positive cranial draw or tibial thrust, when I'm already fairly confident I'm dealing with stifle disease, am I going to take x-rays? And if I do that, then am I going to send them to a surgeon and they're going to sedate them again and take more x-rays? Or should I just skip sedating them here if I feel fairly confident about stifle disease and send them to a surgeon and let them get sedated and x-rayed and everything over there? And I continuously struggle with how to approach these. I'm wondering what your thoughts are on them.
Absolutely. I think you bring up some really great points. To me, the key is taking the time and effort to do your gait evaluation and ortho exam and try to localize first prior to sedating the dog. Because what I do get a lot of the time is sometimes, I'll talk to some referring vets and they'll be like, yeah, this dog came in lame and I just sedated it and we just shot rads of the whole dog. And what do you think? Sort of thing. And they're using kind of the a backwards approach of, well, if I get radiographs of everything, then maybe I can work my way backtrack to a diagnosis. And I think the difficulty there is those radiographs aren't really positioned ideally for any particular joint, and it makes interpretation quite difficult. It can either hide true pathology or it may make something look pathologic, but it's just a positioning. We're not used to looking at that joint in an oblique sort of view to really be able to make a true diagnosis. So what I would encourage is, I think it's great, once you get to the point you're like, I'm suspicious this is a cruciate dog, but I'm not getting a great feel for instability with the dog awake because it's kind of tense. Let's go ahead and sedate it, get a good feel, but also get some good positioned radiographs. And, once that dog is sedate, it will hopefully allow you, just as you said, to compare. Even if the dog does have bilateral cruciate disease, often one side's a little worse than the other. It also gives you an opportunity to get another good feel of the joints. Often our sedation, even though, yes, it's common combination we use all the time is in a healthy dog would be butorphanol and dexmedetomidine sort of combination. But even with that fairly heavy sedation, the dog often still will give you some responses as well. If you get to the painful joint and, you're checking for your instability, often they're not that heavily sedated that they won't still give you a bit of a response. So you still can even localize. And I find sometimes in those dogs that are highly, highly anxious and they're not really giving me much of a localization just because they're so amped up, that sometimes giving them that little bit of the sedation can actually take away some of that anxiety, and they will be actually easier to localize with a bit of sedation on board. So I don't honestly hesitate to sedate, but I do try and do the best that I can with my localization first. And then, once I have got them sedated, I've done my feel, try to get the most bang for your buck for taking those radiographs. Say you have got a cruciate dog, you've localized it to the stifle. Yes, you're feeling a bit of instability there. You're wondering, should I shoot radiographs or not? I would say, yes, go ahead and shoot the radiograph, but include some form of calibration. So we tend to use like a little 2.5 centimeter calibration metallic ball, but there's other calibration markers that you can use, and include that in the film, because that then again takes your film from being purely just diagnostic to being something that the surgeon could use to plan their surgery of. And, just position it. So instead of just capturing just the stifle for your lateral film, include the whole tibia and put the stifle at 90 degrees, tarsus at 90 degrees, get a true lateral view, and include calibration. That film can be used for planning. So you've probably then saved your client about, $300 to $500 for them not to need to get additional sedated radiographs done if they were to go, say, get a TPLO done elsewhere. So it's sort of, to me, just maximizing the value of things that probably people are doing all the time. I see so many great rads, and yet, I still sometimes, biggest reason I have to repeat them is often because there's no calibration included in those radiographs.
I love hearing you say that, because I feel like we can get so much out of that by just adding, obviously making sure we're sedated, and then so we can get that beautiful lateral and the 90-90 positioning, and just adding the calibration ball in. Because when you say, take diagnostic TPLO radiographs, I'm going, no, I can't do that. But when you say, take a 90-90 of the stifle and the tarsus, make sure it's lateral, and put a calibration ball in there, I'm like, oh, I can do that. That doesn't sound bad at all. And I feel like we could get so much information there in GP when these dogs first present. Because if we are on the fence, one, if we get that sedated exam, maybe we get increased mobility in the stifle where we can palpate it a little better. And then we can visualize that effusion that we're looking for on the x-ray. And I think it takes that, like, I don't know, gut squeeze that I get when I'm like, go see a surgeon so that you don't have to get sedated and get multiple x-rays taken and then worry, well, what if they go and then, they go see you and you're like, this is not a cruciate and this doesn't need surgery and you need NSAIDs and rest. And then I'm going, shoot. So yeah, it seems like we could get a lot of information and then really help direct our clients a little bit more specifically while not having this dog get sedated multiple times, get multiple sets of x-rays that the owners are paying for. That it just breaks it down so simply. It feels way less intimidating.
Absolutely. And if, say, you're not sure, or maybe this dog has got cruciate disease, but you also think it could have hip dysplasia as well, instead of like squeezing one film that has both stifle and hip, trying to capture it all in one, get just separate films of the pelvis, as well as separate films of the stifle. Because to me, you're taking it to that next level of being, okay, well, now I have got diagnostic films of both, and I can make a call, on if this dog has hip dysplasia or if it has stifle disease, or maybe it has both. But, I think sometimes we cut corners to try and, I think it's born out of a good idea of saving that client some money, but in the end, it probably doesn't actually save them any money, because if they do come to a specialist and they're like, well, I could see a hint of something, but I'm not sure, that probably might need to get repeated anyway. So, I think there is, like you say, so much value in these tests that we do, and simple things that we can add to make it just more worthwhile for our clients.
Absolutely. And I think one thing that I've found as a major help when we're taking these radiographs and getting them just to be diagnostic, where, like you said, we're not stressing over, can we not see it because the positioning's off, or is it actually, is there pathology there? Sedation, I've become a big believer in, and the time, we're trying to squeeze these in between appointments. Sometimes it's necessary, situations happen, but if we have the opportunity to really take the time to take a good diagnostic radiograph, make sure that patient is appropriately sedated in the plane that we need them in. We just get, I've just become a believer as I've seen the difference in the images and how much we can see of making sure that we have the dog appropriately sedated, that we have the time to take good radiographs, we have the personnel available to do that. And like you said, taking individual x-rays of the joints rather than trying to fit everything in, because I've absolutely done it. And for all the reasons that you just mentioned, and the difference is so substantial, even to my untrained eye.
I think it's also giving yourself the permission to take the extra time to do that. I think, especially I hear people saying, well, I just didn't really have the time to do that. And I'm like, well, the times when we go to a client, we say, hey, are you able to just leave your pet with us just for a little while? We do want to do a sedation, maybe get another exam under sedation, maybe get some really well-positioned x-rays and get a better feel. I've never had a client come back and tell me no, or that they were upset that I was taking more time with their pet. And I think so long as you can sort of justify the reasons why, clients are often willing to do that, to go away, get a coffee, get lunch, come back. And sometimes I'll even do it just for a tricky orthopedic exam. Yeah, this one's a bit subtle. I want to spend a bit more time. I don't have the time to do it right now because I've got another appointment, but I would have a little, chunk of time a little later in my day where I can actually, devote a little more time to just even doing this exam again. And so I think that is something that takes a bit of practice to learn, like when you need it, and then to actually say, okay, well, yeah, I'm going to give myself a little bit of extra time to do this because this isn't something I can squeeze in the next 5 minutes.
Yes, yes. We've all felt that pressure to like try to get the answer right then. But, I think you've done a great job of illustrating how sometimes that actually steers us further away from the answer. And we end up needing more time because now we've doubled the amount of time we need because we have to go back and do it again to really get the answer.
Absolutely.
Well, Dr. Go, I've thoroughly enjoyed this conversation. I learned so much from our talk here that I wouldn't say I'm, have a major comfort level with orthopedics, but it does feel so much more accessible to where I'm going, okay, I can narrow this down and I can take the time to try to at least get in the neighborhood of a diagnosis and know what to look for and when to phone a friend and ask for help. So thank you so much for joining me. Are there any final thoughts you want to share?
No, I just, thank you for inviting me for this conversation, and hopefully can promote more people getting more comfortable with their orthopedic exams.
Absolutely. Well, you're off to a great start with me. So I have a feeling that will be echoed amongst listeners as well.
Awesome.
All right, everybody. Thank you so much for joining us for that episode. I took away a lot from it, as you can hear from my introduction and probably throughout the conversation. And I hope you did too. I hope this makes the orthopedic exam feel more attainable for you in the way that it did for me. Dr. Go, thank you so much. I really, truly enjoyed it. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and find other great content that we're always working to try to put out there. For more episodes, you can click on the education tab on the VetFolio website, or you can find us wherever you get your podcasts. Of course, I want to hear your thoughts on this episode. I want to hear ideas for topics you'd like to hear from us in the future. So feel free. You can reach out to me at dvm@vetfolio.com. We can connect on Facebook at Dr. Cassie DVM, or we can connect on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.